Hello, thanks for joining. We'll wait just a few minutes to let everyone log on. Hello, thanks for joining. We will begin in a moment. All right. Hello, everyone. Thanks for joining us for tonight's webinar as we discuss understanding genetic testing results and other testing implications. My name is Nikki Butler, and I'm the Director of Digital and Social Media for the Dilated Cardiomyopathy Foundation and the Genetic Cardiomyopathy Awareness Consortium. I'm so glad you can be with us as we explore tonight's topic. There's obviously a lot of interest. We have nearly 400 registrants for this thoughtful discussion. So next slide, and actually we can probably advance to the next one as well. So just a few housekeeping items. All attendee microphones are on mute upon joining so that you can hear our presenters. And please enter your questions into the Q&A feature of Zoom at any time. There will be a dedicated Q&A session following tonight's presentations. And next slide. We do have a poll for tonight. Justine, let's push forward poll number 1. We'd love to know who's attending tonight's webinar. Are you best described as a cardiomyopathy patient, a family member or friend, a medical professional, or an industry professional? Just a few more moments there. All right, it looks like about 50% cardiomyopathy patients, 20% family members and friends, 23% medical professionals, and 11% industry professionals. So thank you. And let's keep rolling. I do want you to know that this webinar is being recorded and will be posted on our YouTube channel following tonight's discussion. As registrants, you will receive an email with a link to that recording. Our YouTube channel also houses a library of our previous webinar recordings, and using the auto translate feature, these videos are available in 54 different languages. And next slide. To begin, I'd like to give you just a little background. The DCM Foundation, focused on dilated cardiomyopathy, created the Genetic Cardiomyopathy Awareness Consortium, or GCAC, in 2023. This effort began in 2022 when the DCM Foundation recognized a major gap. Genetics in cardiomyopathy wasn't being widely discussed, not by medical professionals and certainly not by patients. And we realized something important. You can't talk about genetic cardiomyopathy in silos. Many gene mutations cross diagnostic boundaries. For example, a single gene variant might cause dilated cardiomyopathy, DCM, in one person, and arrhythmogenic cardiomyopathy, ACM, in another. Because of that overlap, we needed a broader, more inclusive approach. So GCAC was formed to raise awareness and provide education about genetics and cardiomyopathy across all types. And next slide. In just a few years, we've made meaningful progress. Awareness in genetics and cardiomyopathy has increased significantly, both in the medical community and among patients. When we launched GCAC, we started with 8 patient groups, and today we've grown to 11, and we are continuing to expand. This momentum shows there's a real need and a real interest in understanding the genetic side of cardiomyopathy. And next slide. The 11 patient groups that are participating in the Genetic Cardiomyopathy Awareness Consortium, GCAC for short, along with the DCM Foundation, are Laminate Cardiac, the Danon Foundation, Mended Hearts, PLN, SADS Foundation, Women Heart, Let's Talk PPCM, Team Titan, Heart Charged, and the Sudden Cardiac Arrest Foundation. We want to thank each group for participating. It's great to have a coalition of 11 different groups working together to solve a real problem with patients. And next slide. We're excited to have 3 speakers this evening: licensed genetic counselor Cara Barnett. Shauna Planck is the medical outreach coordinator for the DCM Foundation and also a cardiomyopathy patient. And Greg Roof, DCM Foundation executive director and also a cardiomyopathy patient. And next slide. So Cara will kick off our discussion to help us understand genetic testing results. Shauna will share her personal story along with advice for talking with your family. And Greg will discuss insurance considerations surrounding testing results. And we've allotted time for all 3 of them to answer questions at the end. So next slide. Let's get rolling. We are pleased to welcome Cara Barnett tonight. Cara is a licensed genetic counselor specializing in cardiovascular genetics with experience across both pediatric and adult academic medical centers. Her work focuses on understanding how genetic variants relate to heart disease, supporting conversations around emerging cardiomyopathy therapies, including gene therapy, and expanding access to genetic counseling through innovative telehealth models. She is actively involved with the National Society of Genetic Counselors Cardiovascular Genetic Special Interest Group and serves as a biocurator with the NIH Clinical Genome Resource. We're grateful to have her expertise with us tonight. So I will turn it over to you, Cara.
Perfect. Thank you for the introduction, Nikki, and thank you to GCAC and the DCM Foundation for having me join the webinar. So for my section and the whole webinar, we will discuss genetic testing for cardiomyopathy very broadly. Not all genetic testing is the same. Not all genetic diagnoses or cardiomyopathy diagnoses are the same. So this is broad educational material and not medical advice. We recommend speaking with your cardiologist, your primary care doctor, or a genetic counselor for specific recommendations about your case or your family. Next slide. So to start with, what is genetic testing? There are many different types of genetic testing, and we'll focus mainly with the concept of gene panels, which are genetic tests looking at a specific number of genes that are related to a specific type of disease. So there's many labs that have cardiomyopathy gene tests or gene panels. And what these tests are doing is they're reading through genes related to the heart to look for changes in their spelling. We all have 2 copies of every gene. We get one from mom, one from dad. And what we're looking for is typically these genes work normally and support the heart in ways that they should. We're looking for bad spelling changes, which are often called mutations or variants. Not all changes in a gene's spelling are bad. There's some that are just totally normal diversity within our genes. But when a spelling change in a gene is bad and causes the gene not to work, that's called a pathogenic variant. So we'll be talking broadly about testing and referencing looking through the genes to look for answers for a cardiomyopathy. Next slide. So when genetic testing is done, you and your medical provider receive a report back. The order and who it goes to first depends on who did the testing, how it was ordered. But once you get a copy of that report, you'll see it includes your demographic information, as well as the name of the test that was done. Oftentimes you'll see cardiomyopathy gene panel or cardiomyopathy and arrhythmia panel. It'll include somewhere on the test all of the genes that were tested. Usually that's towards the end of the report, as well as additional technical information about how the test was done. On that first page, somewhere towards the top, you'll often see your results. There's usually a banner on the report that says your results. If it's a negative result, there won't be any specific genes listed. It'll just say negative. If it's a positive result or there's a change in a gene, it'll say the specific gene change found and what that means. There's some nuance to what that can mean, and we'll talk about that in the coming slides. Just because a gene change is listed doesn't always mean it's the answer. So we'll go through some scenarios of what we can see. Next slide. So for additional details on the report, if a gene change is found and listed, they'll include the information about that variant. It'll include the name of the gene. I've included some common cardiomyopathy genes as an example, and it'll include the exact change that was found. So our testing is very precise, and it tells us exactly where in the gene there was a change in the spelling and what that does to the gene, which gives us more info on what's happening or why the gene's not working. It also will tell you whether that gene change is in one or both copies of the gene. Statistically, most cardiomyopathies are due to a dominant mutation, where you only need one mutation in one copy of the gene to have a risk for heart problems. So it'll tell you whether that mutation is in one or both copies. And then it'll also tell you whether that or how that mutation or variant is classified. So it'll tell you if it's considered a true positive or maybe something uncertain. And we'll talk through what that means. Next slide. So exactly what I was alluding to, there's different types of results. There's negative results, uncertain results, and positive results. So we'll go through each of these. Next slide. So this is an example of what a report might look like. So on the top half of this slide, we see an example of what a positive result can look like. Not all reports have this type of table. They can be formatted differently, but you will see the name of the gene, the specific variant that occurred, and the zygosity. The zygosity is referring to whether or not there's one or two changes found. Here, heterozygous means that this change is in one copy of the gene, and the classification. Here, the classification is pathogenic, which means that it's a positive result, and in this case, known to cause cardiomyopathy. There can be some nuance with testing, and a pathogenic positive in some cases might not always mean it's a super clear answer for you. So in general, yes, this means we found the answer, this is the cause, but we always recommend, of course, talking with your medical professional about the results so you can be confident. On the bottom half of the slide here, we have an example of an uncertain result, where the same information is listed. We see the name of the gene, the specific variant or change, the zygosity, so this is in one copy of the gene, it's heterozygous, and the classification as uncertain significance. If a gene change is listed and it's considered uncertain, this means we don't yet know if it causes disease or causes cardiomyopathy. As I mentioned earlier, there are some changes in genes that are benign, normal changes in the genes. We have a reference data set for what the typical spelling of a gene is, but sometimes there's variations that are just normal things in your family where it might not cause disease. It's just a normal change that makes us different and makes each family different. So that can end up on the report as an uncertain result. And we'll talk more about what that means in the clinic medically, what we do with that. Next slide. So for negative results, if you yourself have a diagnosis of a cardiomyopathy and genetic testing was ordered and it comes back negative, this means that a genetic answer was not found. It wasn't found today. It doesn't rule out that there is a genetic risk or that family members could be at risk. It strictly means based on our testing today, we couldn't find the answer for you. Genetics is complex and our technology is always changing and improving. So maybe we could find the answer in the future. This can sometimes be referred to as gene-elusive cardiomyopathy. We often use that term if we have a family with multiple people with a type of cardiomyopathy, but our testing currently isn't able to find an answer for you. There's lots of cardiomyopathy genes being discovered and some genetic changes that our testing can't detect, where certain parts of the gene are hard to get to with testing. So testing is always changing and improving. And if your diagnosis of cardiomyopathy and genetics is negative, you can always consider updated testing every few years. In these situations, we do recommend that family members have screening of the heart. Because even if we don't find the answer, families can still share heart conditions and they can still run in the family. So the Heart Failure Society of America recommends first-degree relatives, which are parents, siblings, children, of someone with cardiomyopathy and a negative genetic test, continue to have regular heart screenings throughout the lifetime. The specifics of this recommendation should be discussed with your cardiologist and your family members as well, but they should have ongoing heart screening. Next slide. For a positive result, we're going to talk through this as if we find a positive and it is a clear answer for the cardiomyopathy. That is what we find sometimes. And if we find this clear answer, it can be really helpful because it can help your doctor choose the most appropriate care. There are situations where a positive result can impact our care planning and our medical management. It might tell us about risk factors we didn't know about before we had this result. It also can be really impactful because it can tell us that there's genetic testing available to family members to understand whether or not they're at risk for cardiomyopathy. So when we have a positive result, we should talk about it with our doctors and our care team, our genetic counselors, and then also discuss how we should talk about it with family members. And Shauna will talk more through those nuances and considerations when discussing a positive result with family. That positive result is really impactful because we can offer testing to family and know whether or not, yes or no, they have a risk to develop cardiomyopathy. Relatives who would test positive for that same gene are at risk to develop a cardiomyopathy or heart condition and need ongoing screening. And sometimes that gene can give us info about the type of screening even that's best for them. If you have a positive result that's a clear answer for you and your relatives test negative, then they don't need ongoing heart screening. We know they don't have that risk factor. Genetic testing is truly easier than ever with a lot of new telehealth options and initiatives to help provide individuals access to testing. And this is something you can find online, talk with your family members about, and Greg will mention this later as well. First-degree relatives who do not pursue testing when we have a clear genetic answer in the family should continue heart screening as if they are at risk, because we truly don't know whether or not they have that same variant or mutation. So we would recommend they continue to have their hearts screened clinically until they either consider testing or just if they want to keep screening, so that we can make sure we're taking care of them and not missing something if they were to develop any heart problems. Next slide. For the uncertain result, these are often referred to as variants of uncertain significance. Not all labs or tests report uncertain variants. It can vary and there's some nuance. So that's something you can always ask your genetic counselor or doctor about. Were those included? Was there anything else seen? But in general, an uncertain result means that a change was found in a gene, but we don't know exactly what it means. We don't know if it's a true negative where it doesn't do anything, or if it might be a positive and have some sort of risk. There are changes that are just normal genetic variability. And when a lab applies all the guidelines and their data and they can't say for certain one way or the other, they put it on their report as an uncertain result. Next slide. In general, we do not use uncertain results to inform your care or family members' care. And that's because we would never want to use something uncertain to make decisions and then find out we're wrong about it. So at the end of the day, it's always best to provide recommendations based on what we can see and know in clinic. So there are guidelines just based on diagnosis and family history, regardless of the actual test results. So in general, we often consider these uncertain results as negative results until we get more info. It could be that this uncertain result does mean nothing, and there's another gene out there that's actually the answer. Or maybe in the future we learn more, and this uncertain result does mean something. But until we know for sure, we typically play it safe and say, we're not sure exactly what this means. We'll continue to screen family members and treat you based on your symptoms. Family members can still share heart conditions even when we don't find the answer or testing's uncertain or uninformative. And that's why we continue to recommend that first-degree relatives have heart screening for cardiomyopathy risk. There are rare cases where a genetic counselor might say, or your doctor might say, I'm really suspicious this is actually the answer, or for XYZ reason, I'm saying that this is the answer. That's something that can happen. And in those cases, of course, we defer to your doctor, your medical team, to help you understand and help interpret these results. Next slide. So in general, recommendations for everyone would be to meet with a genetic counselor or your care team to review questions about your specific case, if you've had testing to review your results, or talk about what testing is available. Results should be shared with your entire care team. This includes your cardiology team, genetics teams, as well as even your family doctor and primary care doctors can be a beneficial resource. It's important to talk to family members about both a cardiomyopathy diagnosis in general, as well as what the genetic testing results were and what they could mean. And Shauna will dive more into the considerations and recommendations and ideas for this. If we don't find an answer now or testing's uncertain, updated testing can be helpful every few years and should be considered. And that's something you can ask about and help remind the team about every few years. Ask about it, ask for updates. Even if you have positive results, we're learning more and more every year. So you can even ask for updates on, hey, is there any more specific info on my gene that I have? Because there is more that comes out each year. Genetic counselors are a very useful tool and can be found through the National Society of Genetic Counselors website, or specifically for cardiology, the Cardiogenomic Testing Alliance, or CGTA, has their own Find a Genetic Counselor tool, which includes a map where you can put in your location and whether or not you prefer telehealth or in person, and find genetic counselors that way, as well as their direct contact info. So you can reach out to them with questions or requesting to meet with them for a visit. Next slide. So I will pass it off to Shauna to talk about talking with families and patient support resources.
Thank you so much, Cara. That was really informative, and we already have some questions coming in, which is great, so keep them coming. And I am Shauna Planck. As Nikki mentioned at the beginning, I am a cardiomyopathy patient myself. I have a mutation in the lamin gene that I did inherit. And so I'll be talking really from the patient perspective of what it looks like, why it's important to have a conversation with your family if you do have a positive test result. And something important to note is that this diagnosis can affect your family members too, whether they're as caregivers or if they end up being positive themselves. So I'll cover how to start those conversations, what that looked like for me, what you can expect in terms of responses as you navigate this with different family members. And then I'll also hit on support resources that we have. So I'll tell you when to grab your phone. We have QR codes to direct you to relevant pages, and then we'll also send them out after the webinar. On the next slide here, you'll see a little bit of my story. I'll just go through it very briefly. So it actually started in 2012 when my dad received a heart transplant after years of end-stage heart failure. So that was him, age 57, 2 weeks post-transplant, 14 years ago, and now doing well. And at that time, his care team was insistent that there was not a genetic component. And I think this is a common thing that many patients I talk to have experienced. But actually 2 years later, I went through, for different reasons, some genetic testing. And at that time, I did get a variant of uncertain significance on my test report. So I had a variant in the lamin or LMNA gene, but at the time it was considered kind of unknown how that would impact me. So you see that's my husband and I climbing a 14,000-foot peak. I live in Colorado, so kind of living an outdoor active lifestyle, continued doing that, didn't really think anything of it with those results. Flash forward to 2017 when I was pregnant with my son, and I had another test done for another reason. And actually at this time, now that test result came back as pathogenic, which we just heard from Cara means, likely disease causing. And so that really changed everything from my care. Fortunately, I had a great cardiac team who I'm still with today, and they were able to help safely get me through that pregnancy despite some issues. So that brings us to today. I'm traveling. That's a picture on the left of me with a lion in the background, which was my dream bucket list vacation. I was able to go on to South Africa last year. But I also was in the hospital a few times last year, just managing my disease. And so that's where I stand today, but I'm hoping to help other patients along the way who are going through a similar journey. And after this diagnosis, I was still pretty confused. I didn't really understand what it meant for myself, but also for my family members. What did that look like for them? And so I'll go through kind of how I approached it on this next slide here. So what this looked like, and I want to be really clear on a couple of things. One is that as much as I'd love to say that I navigated this 100% with grace and it went perfectly, of course, it was reality, right? It didn't go that way. And so these are some of the things that I learned along the way. And then we also have some tips that we've put together that can help you. So number one is I started with my immediate family. Obviously, we all knew that my dad had been transplanted and that I had complications in my pregnancy. So that really kind of set the context and the tone. But I was able to start with those that I was closest with. And then I also introduced cardiovascular genetic counseling. I had an amazing genetic counselor who walked me through my results and was happy to facilitate testing for my family members, both in state and out of state as well, which was extremely beneficial. And then lastly, it was kind of a reality check, right? Some family members said, I want to be tested right now, which was great. And then others chose to wait. They weren't quite ready yet. And they did start seeing a cardiologist. We heard Cara mention that it's important to continue to be screened. So fortunately, I also had some family members who said, I'm not ready to be tested, but I'm going to get myself checked out, once a year or whatever their cardiologist recommended in the meantime. And then I have some family members who have still chosen not to be tested and not to see a cardiologist. And so something that I really learned through this process is that everybody processes this information at their own pace. They have their own beliefs about the medical system or how they get their care. And it was really important for me personally to respect that and give them the space that they needed. And I'll also add that this conversation is really focused on adults in my family. If you have children who may be affected in your family, especially if they're minors, that's its own ballgame. And so I really recommend connecting with your genetic counselor to help you weigh the pros and cons, how to navigate that, specifically with younger children. So let's move on to the next slide. And here are some tips that we've kind of put together over the years from my experience and others on our team. Is number one, having that family tree which your genetic counselor can help you build will really help you identify, who's at risk, who is it most important to have this conversation with. And the second piece of advice here is to lead with information and not fear, right? Stick to the facts. We know this is really scary. If you're having this conversation, you most likely already had a positive test result and you've been processing it yourself. So sticking to some of those facts and kind of laying out your plan before you approach the conversation can be really helpful. Next is there are many resources out there. So you can have your genetic counselor help you with a written family letter. You can leverage a flyer that you find online. You can send a link to a support group on Facebook or an expert video. We have all of those available, and sometimes they may resonate more or less with members of your family. So you can kind of pick and choose how much information and which format might be most relevant. Number 4, listen and answer questions. So write them down. It's a great opportunity if you don't know the answer to write those down and bring them forward to your care team or your genetic counselor at your next appointment. And then if you are comfortable and it feels right, you can encourage them to get genetically tested, right? Emphasizing that it is a personal choice as much as we'd love to take everybody we care about and, kind of guide their path. Really, it's ultimately their decision and we're here to support them and respect them, but also encouraging them to make sure that they're getting appropriate care, whether that's getting genetically tested now or getting in to see the cardiologist or both. And then lastly, it's okay to revisit that conversation later or ask someone else to help you explain. Chances are that they're going to need some time and that's okay. So give them the time and space that they need and you can always have, ongoing conversations as time goes on. Let's go to the next slide. I want to also emphasize some of the support resources that we have available through GCAC and the DCM Foundation. And these are things that personally really helped me. On the left-hand side, you see an example of one of our gene-specific Facebook support groups. I'm a member of that one, along with 999 of my best friends. And it's been a huge lifeline for me. We have over 20 groups now, 3,500 people represented, and they can provide a lot of support as you navigate these conversations as well. Likewise, in the middle here, you see we actually have a number of gene-specific expert videos with various physicians and researchers across the country. So I highly recommend checking those out as well. Again, we'll provide a link so that you can find that information. And it really is a great resource for you, and maybe sharing with family about what to expect and what it means when you do have this diagnosis. And then lastly, Nikki at the very beginning showed our partner organizations. The 3 that I've listed here were really beneficial to me early on in my diagnosis and continue to be to this day. You know, I work for DCM Foundation. I volunteer with LMNA Cardiac, and then Women Heart has some great programs as well. So I encourage you to find kind of what works best for you if you are looking for support. There are many ways to get support, and there's kind of something for everybody. Let's go to the next slide. So those are the QR codes I promised. Again, we'll have these at the end and also by email after the webinar. But our point is that you don't have to do this alone, right? There are many ways, many resources, people who can help you figure out how to have the conversations so that when you're ready, you can approach them with grace, or whatever that looks like for you. And they don't have to happen all at once. You can process your own diagnosis first and then start small. Maybe pick one family member to have a conversation with and have one brief conversation. Look into one resource that might help provide you support, and just really focus on one step at a time. When you do get this diagnosis, it's for life, right? So there's some time to build up your support system and navigate how you want this to look for your specific scenario. So the links you see there are, one on the left, the patient support page. So we have a lot of resources to provide you with supports. And then we actually have a chat with your family page as well that I highly recommend and encourage you to visit if you are in this situation, because some of the tips I reviewed are there, and along with many other ideas and tips and tricks to help you kind of navigate that with your family. So with that, let's move forward. And I'd like to thank you for your time, and I'll pass it on to Greg Roof to talk about genetic testing and insurance considerations before our Q&A. Thanks, Greg.
Thanks, Shauna, and Cara. Thanks so much, Nikki. Thank for all of you attending. Again, we had almost 400 people register and 135-40 on tonight, which is sort of the normally way it happens. But thank you also very much for your help, and Justine behind the scenes. Genetic testing insurance. Next slide, please, Justine. So the areas of potential discrimination with a positive genetic test, I'm going to run through. There are 5 areas potentially. One is health insurance, and our laws today say that they cannot discriminate. We'll go into this in more detail. Employment, the laws today say no, especially with greater than 15 employees. Life insurance can discriminate. Long-term care can discriminate. And disability insurance can discriminate. So we'll talk about that. Next slide, please. So when you look at health insurance and employment, federal law prohibits and has strong protections against discrimination in health insurance with the GENE Act of 2008 and the Affordable Care Act of that was passed. I think it might have been 2008 also. So with health insurance, companies cannot use genetic information to deny coverage, insurance premiums, or impose existing exclusions. Under employment, under the GENE Act, that employers with 15 or more employees cannot use genetic information to make decisions regarding hiring, firing, job assignments, promotions. But also check your local state laws. There actually may be some additional protections in there, and that goes state by state. Note below, it's very important to note that these protections also apply to predictive genetic information for asymptomatic individuals. If you've already been diagnosed with a condition, other laws regarding pre-existing conditions and medical information may apply. Now, let me say something here too, because we get this question a lot. So if you are tested positive for, or you are a cardiomyopathy patient, you've been diagnosed, and you want to figure out what caused it, and your cardiologist says a way to potentially determine that is genetic testing. If you are already diagnosed with cardiomyopathy, you're already on the naughty list. So it's unlikely that the genetic test would cause you any additional insurance concerns. Again, I say that because there's 1 to 1.5 million people probably with genetic cardiomyopathy in the United States, but only 1.1% of the people have been tested. So realize if you've already been diagnosed with cardiomyopathy, you're going to be discriminated against anyway. Next slide, please. Again, let's talk about life, long-term care, and disability. Several types of insurance can discriminate with either higher pricing or potential denials. This includes life insurance. High-risk results may lead to denial or significant higher rates. Long-term care, the insurers can use these results to determine whether you're eligible for long-term care or not. And then disability insurance. Genetic predispositions can lead to an increased costs or exclusions. And again, as I mentioned before, even with these, these are federal laws, check your state laws to see how they apply. There may be some additional protections above GINA to cover this. Also remember that disclosure is required. Failing to disclose known genetic information when applying for non-health insurance can be considered fraud. So you want to make sure that you're being honest. Next slide, please. So some key considerations are on this is the timing of testing. And so one of the things that's been recommended, and actually my family did this also, is, and experts and genetic counselors often suggest this, that before being tested, potentially secure a life, disability, long-term care insurance before going under genetic testing to avoid potential negative implications, cover your costs. Again, if you're dealing with a genetic counselor, these are questions you can ask them. And also, if you have an insurance representative, these are also questions you can ask your insurance representative. Again, any of the direct-to-consumer tests like 23andMe can also become part of your medical record if you share with them, if it's shared with a healthcare provider, and they can make that accessible to insurance underwriters. Again, privacy. Be very careful and mindful of the direct-to-consumer testing companies, as they may share data with third parties, even though the major ones typically do not share with insurance companies without consent. Next slide. This does not have to deal specifically with genetic testing, but I think this is really important, and I always try to share with people. There are other key financial considerations when you have cardiomyopathy. One is health insurance, obviously, which I'm sure all of you know. And one of the things that I always, when I talk to patients, is that it's extremely important that good health insurance is top of mind when changing jobs. You may look at a job with a much worse health insurance policy that pays a little more, and make sure that you really go through the numbers and understand that you may be better off with a better health insurance policies. And if you're changing policies, again, chronic illnesses are expensive. Make sure that you can get within what you can afford the best health insurance policy possible that covers the tests, the medications, things that you deal with cardiomyopathy or a long-term illness. Denials. Again, I genetic cardiomyopathy patient, heart failure for 7 years, heart transplant, denials. You are going to get denials for necessary tests and treatments. Work with your medical team to get approvals. Don't give up. Fight it. Be dogged. My belief is that a lot of the health insurance companies are going to send denials out to a certain percentage because a lot of patients just don't fight back. If your doctors say it's necessary, fight back. Work with your medical team. They always will help. If they think the test is important, they will work and fight with your health insurance company. Last thing is prescriptions. Cardiomyopathy, there's a lot of drugs. They can be very expensive. So make sure that whether you have insurance or not, always check with multiple pharmacies. local and online, there's a ton. There's a ton of good. Mark Cuban's got a great one. There's Amazon, right? There's Express Scripts. Check your local pharmacies, check online for best pricing. Also check into discount programs. Actually, for a couple of my meds, I use a discount program like GoodRx to get my drugs. It's actually cheaper than my copay with my health insurance company prescription program. And then also many of the people that manufacture their drugs. So for instance, I know Novartis with Entresto, when I was taking it, very expensive drug. I was able to get, I think, a year of Entresto for just a $10 copay because they had a program. So you can go onto the sites, look who manufactures the drug that's being prescribed, look on their sites, and see if there are any programs where they'll actually help pay or provide assistance, because that happens a lot. Next slide, please. I think we are now at the Q&A, which I will actually moderate. Thank you. We'll bring Cara and Shauna on. The one thing, and we have 20 minutes, which is great because there's a lot of questions. We have 17 so far. We will go through them with you. I'm going to read through each. Some we may not be able to answer. Some might be, one of the things, some might be medical questions that we just can't answer. So Cara, Shauna, Greg, we'll try to answer your questions and help you, but this is not medical advice. This is either, a qualified person that understands trying to help you out and answer your question, or this is someone that is a patient that has become somewhat, gained some knowledge in this. But again, whatever we're talking about is not medical advice and should not be construed as medical advice. First question, I have been found to have the FLNC gene alteration. I do not have cardiomyopathy, but my mom does. My cardiologist said I do not need an ICD as I may not develop cardiomyopathy like my mom, and I would only need one if worrying signs, symptoms, if there are worrying signs or symptoms. Is this right? Cara, I can take a shot at this. I don't know if you want to or not, but
You want to go first? I'll follow up. Go for it.
yeah, again, I think the thing is we don't have enough information, right? So we need all your medical records, everything. And again, we couldn't tell you anyway. The one thing that I always say is, do you obviously, if your cardiologist has tested you, they understand genetics and cardiomyopathy. So, and there's treating your mother, that's really important to find a cardiologist that understands genetics and how to treat genetics and to treat specific gene mutations that cause cardiomyopathy. If you feel comfortable with that, I think that's great. The other thing is that a heart failure doc, if it's a heart failure doc, you may want to consult with an electrophysiologist that understands and understands genetic cardiomyopathy. Cara, anything?
Yeah. So FLNC or filament C is one of the genes that has more specific guidelines for it. And typically, for the most part, the guidelines say you don't get an ICD unless you have severe cardiomyopathy already. Of course, things should be patient and family specific. So that's not specific advice for you. But guideline-wise, it says to consider an ICD earlier than other people when you have disease. Of course, things can vary between families though. So I would, talk to them more about why they're saying that, ask them for more details so that they can help make sure that you're reassured and that you're comfortable and confident in what they're telling you. Because what Greg said is so right. You want someone that understands the testing, understands the result, and he's spot on. If they ordered you testing, they probably understand it somewhat, which is a great start.
Great. Thank you very much. And this next one will be for you, Cara. Why do some positive results with the pathogenic variant end up causing DCM and some do not? Are my family members definitely going to develop DCM if they have the same pathogenic variant? Cara?
Yeah, great question. So I would say, like, in general, like positive result usually means we have the answer for you. This is why you developed it. It's a known risk factor. Not everyone who has that positive result will develop symptoms at the same time, the same age, the same severity, the same type of symptom. These genes can cause typically kind of like a diverse range of symptoms where some people get arrhythmias first, some people get mild heart failure. Some people get severe cardiomyopathy. It can be variable. So for the most part, if we get a positive result and it's the answer for you and other people test positive, they are at risk, but they don't always develop it and not always at the same age or same stage. And different genes have different risk numbers and risk factors. So I would ask like your medical team for more info on like, I have this gene and it's the answer for me. For my family, are there some general numbers I can say about if you have this too, kind of these are the general risks. We don't know everything, and those numbers can be kind of broad and ranging. But in general, most of the time it's a clear risk factor. And that's why we recommend testing people because it tells us yes or no, you're at risk, but it's not a crystal ball. And that's often the biggest drawback is it can't tell us exactly when or how or what it might look like.
Great. Thank you. Thank you. And this is from Elizabeth. Can you have more than one pathogenic mutation?
You can. So there are some people that do. It's less common. Like most often people just have one, but we absolutely see cases every year where people can test positive for like two true positive risk factors. It can happen. And I would, of course, defer to your team who ordered the testing to help clarify, of course, if that comes up.
Thank you. And this is from Rob. Do the positive results show it's from one side of the family or is it split 50-50?
Excellent question. Your test would not tell us anything about which side it came from. It just gives us info about you. If there's a family history, we can start to make kind of like suspicious curiosity it's from one side or the other. But the only way to know would be to test parents or test people on both sides of the family. So we don't know from your test. We would recommend testing other people to figure that out. But typically it's only from one side or the other, not both.
Great. Thank you. From Kara, I think probably pronounced,
Mhm.
is the risk the same for developing disease with a heterozygous PKP2 mutation as someone with two variants versus just the one?
I would say it depends on the specific case. So that's one where I would probably not like it. Risks can vary with that gene based on the result. So I would talk to your specific doctors about the result to get more info. Yeah. That's not one we can easily provide insight into without seeing it.
Great. Thank you. What is the most up-to-date testing panel for cardiomyopathies? Do I have to get a doctor to request a test, or can I do this with LabCorp?
Excellent question. I think Greg and I can both answer this. So there's many different companies that offer up-to-date panels, and they're all fairly similar. You ask 10 different people, people will have different preferences, but they all include the core genes. Not all testing requires a doctor first. There are different patient-initiated programs to get testing, and I'll let Greg provide a little more info on that and some resources the foundation has put together.
Yeah, great. Thank you. We've got we're going to have a slide at the end of the presentation, or you can go to geneticcardiomyopathy.org and look at get genetic testing. And there are some free options. There's several options there. But again, you can also go to your doctor and request the test. And it could be from another number of different. The big thing is that you want it to be, I think, CLIA and CAP certified. There needs to be a certification, which probably most labs are now, I would think. So, yeah.
Mhm. Yeah,
Uh,
that's a great point. There are some predatory online programs that aren't CAP CLIA certified, just like Greg said. So you can seek it out yourself, but I would talk to a medical professional, talk to a foundation to make sure it is like real clinical quality testing.
Thank you. What is the difference between a panel genetic testing and WGS, and which one is better?
Mhm. I wouldn't say one or the other is necessarily better. It depends on the reason we're testing, what we're looking for, and sometimes even just like logistics of is it going to be a few $100s or $1,000? And it can really vary. Most people these days, testing is not more than a few hundred. Of course, there is nuance, and I'm sure people on this call would say, no, that's not what happened for me. But it's something you should talk about ahead of time. Not one or the other is better. The difference is more like how the test is designed and the extent of data it looks at. Genome sequencing does look a little more deeply and a little more broadly than a panel. It includes a bit more, but statistically, with these types of conditions, we don't know if that is always much better or not. There's a lot of data we don't have yet. So it's hard to say one or the other is better. I think in some cases, whatever one you can get access to start is a great start. And if we want to reevaluate options in the future, we can do that too.
Great. Thank you. Do you need to provide heart tissue to get genetic testing or just a cheek swab?
Yeah, just a cheek swab. Awesome question. It is so much easier now than it used to be. A cheek swab is just as good as a blood draw as other samples.
Great. And Shauna, we've been ignoring you. It's not a question for you, but Elizabeth says thanks for sharing your story. So thank you. Thank you, Shauna.
Thanks, Elizabeth.
From Jim. Hey, Jim. Under the classification of this test, it says likely pathogenic, TTN. Does likely mean positive, maybe, or probably? That's actually a really good question.
Awesome question. So likely pathogenic means it would be a positive. The word likely is there because we use a strict, published, nationally adopted scale for how to interpret these results. And with this scale, you can go from benign to uncertain to likely pathogenic to full pathogenic. A lab typically would not use the term likely pathogenic unless they are confident it's positive. It just didn't meet the total threshold to be a full pathogenic. But if your medical team says, this likely pathogenic is positive, it's the answer, I would trust your medical team and what they say.
Perfect. Thank you. And along this line from Christy, hey, Christy, trying to understand more about VUS because I've heard several stories of people whose VUSs have been converted to pathogenic. Does a gene variant get classified as a VUS because it has not been seen before or seen enough to be classified as pathogenic or negative? Or is it because where the protein change on the gene is located may not cause enough change to make the protein ineffective? Oh, that's a good question.
Yeah, it's a good question, and you kind of answered it yourself. So it's both. The points like system scale used to classify these gene changes takes into account lots of different data, which can include how many times it's been seen, what type of change it is, where in the gene it is, what the predicted effect is. So all of that goes into account when something ends up as uncertain versus positive. So an uncertain variant, I would say a lot of the time it's just there's not enough data. Like we barely have any data. We might know it's not in the population or it's there at a low level, and that's it. And when they get upgraded or converted, that's typically because we got new data where someone studied it in a lab or, 30,000 more people got tested and we got this additional info to feel confident and add that point value or give us more info. So it's a mix of everything. Most of them, there's just not enough info. And as we get more info, it becomes more clear.
Perfect. Thanks. Real quick, Car, is there like a government agency that sort of sets the standard for VUS likely path or path, or how does that work, if I could ask?
It's a great question. So every lab does do it a teeny bit differently. They have some like leeway and ability to set their own kind of variations on the guidelines, but the guidelines are coming from the American College of Medical Genetics. So the American College of Medical Genetics sets the standard. They published guidelines, and there's even like individual gene guidelines that are coming out from expert groups at like the NIH and medical centers across the country that work together and volunteer their time. So it is like a genetics governing body essentially that has put out these guidelines and updates them every few years. So we're actually due for an update coming in the next few years.
Perfect. From Carrie, I had cardiac genetic testing to rule out cardiovascular EHLERS-Danlos syndrome and incidentally tested positive for an RBM20 gene. Studies show it is highly pathogenic, often with early severe onset of cardiomyopathy and ventricular arrhythmias. I'm 39, don't have any symptoms or sign of disease. My teen daughter tested positive for RBM20 gene as well. However, the cardiologists we have seen are not familiar with the gene. Is it important to find a specialist who knows and has experience with your specific gene mutation?
Hmm. Do you want to start, Greg?
Yeah, I think it's really important. I think one, you want to go to, an academic medical center near you that does a lot of, genetic testing and has a lot of heart failure cardiologist specialists that understand the genes. You can email me at info@geneticcardiomyopathy.org, info@geneticcardiomyopathy.org, and I can help you out and give you some answers. But I do think it's important. Anybody that has genetic cardiomyopathy should be seen by an institution that understands genetic cardiomyopathy. And I can try to find you a couple of the top experts in RBM20 if you'd like to. So, Cara,
Yeah.
what do you think?
Yeah. I typically tell my patients, you will take this result to cardiologists and they might have never heard of this. And that wouldn't surprise me. And it's just because we all are trained differently, all have different expertise. What matters is definitely finding a cardiologist familiar with familial cardiomyopathies and genetic cardiomyopathies broadly. There are RBM20 experts. We're happy to connect you with them. But even if they don't know your specific mutation, because some mutations are unique in families, as long as they know broadly, like genetic cardiomyopathy, ongoing screening, we can help you kind of understand. And through our patient groups, Shauna might even have insights into like understanding, am I getting the right care? Is enough being done?
Great, great. We may go 5, 10 minutes over if it's okay with everybody. We got a ton of questions. So we may not get to all of them, but we'll do the best we can. From David, my positive result was from tissue that I donated to a blood bank many years ago, and I've never received anything more than a phone call telling me that I was positive for ARVD, genetic cardiomyopathy. How can I get a copy of the actual genetic test? It's been about 2.5 years.
It's a great question. So typically, like you should be able to recontact someone with the tissue bank or the research study. If that becomes a rabbit hole that you can't get answers from, you can always be retested. Get tested again through a clinical lab or directly where you can get that report in your hands. So I'd say try contacting maybe those original people, see if you can hunt it down. And if you can't, and you want that copy of the report for your doctors and your family, absolutely you should have it. And I would get retested if you have to.
Perfect. Thank you. From Ronnie, is there specific benefit of being tested if you already have cardiomyopathy and under the care of a cardiologist?
Yeah, great question. So the main benefits are there are some genes where it could change your management. That's not the most common, but it can happen where some have higher risks and we treat you differently and follow you differently. And I'd say like the number one thing we talk about with families is if you have a cardiomyopathy and we test you and find an answer, we can provide more clear information for your family about their risk. So a big part of it is it doesn't always change your treatment, but it could be really helpful for family members to understand their risk or have more options. And yeah, Shauna and Greg, if you have other thoughts too, being more like immediately in that position.
Yeah, I can give it a shot, And so the guidelines are from the American Heart Association, American College of Cardiology, and the Heart Failure Society of America are that if you are diagnosed with idiopathic or non-ischemic cardiomyopathy, you should be genetically tested, which means we don't know why you have cardiomyopathy. So they should be testing you. I mean, it's the guidelines. They're not, and it's criminal that in this country that's happening actually, and we're trying to change that. But there, as she said, for instance, some genes can cause arrhythmias. And if the gene that you have, there's actually a list of recommended, if you have this gene that's causing cardiomyopathy, you can get an ICD, and health insurance, the vast majority of the time, will pay for it to protect you in case any dangerous arrhythmias, start to present. That's a huge case, actually. And then also, if that's the case, you would want to get first-degree relatives tested too, so that they can actually be managed so that, like my kids are, tested every several years, like a cardiogram, ECG, maybe a Holter monitor, every so many years, a cardiac MRI to make sure that the disease is not developing And it's really important if it does, they get an ICD and they would probably start some drug management to help slow, the progression of the disease. So, what are the recommendations for travel insurance with pre-existing diagnosis for HCM? Shauna, I've never had problem getting it, but I just apply. But Shauna, what is your thought
Yeah,
there?
no, me neither. But my advice is to check out the insurance criteria. So I try to travel quite a bit, and I generally within 2 weeks of making your first payment on a trip or anything is when you need to buy insurance for it to cover pre-existing conditions. So you want to get it kind of right away when you book a trip. And so I would just talk to a travel agent or the insurance company and make sure that your pre-existing condition would be covered and that you don't wait too long to purchase it, in which case it wouldn't be covered.
Cool. James says, I have a pathogenic mutation of DSP gene, and I also have mutations of unknown significance for TNN13K in bag 3 from an October 2024 test. Should I get retested? My sister is negative for DSP in bag 3. She does have an unknown significant for bag 3 gene, severe shortness of breath. She's a bit obese. What do you suggest for her?
Great question. I wouldn't retest you yet. At this point, that testing's still up to date and accurate, kind of broadly. Of course, not medical advice specifically, talk to your team. But it's always a good idea to check back in with your genetics team. Are there updates about these uncertain variants? Do we know anything new? Um, so I would ask them to reevaluate it, and they can tell you for sure whether or not any updated testing would help. For your sister, I would say she should talk with a genetic counselor and consider seeing a cardiologist to make sure that, she's comfortable with the care plan and that she's been evaluated and understands the results.
Great, thanks. From James, I talked to my cardiologist about my results, and he said at this time he does not use positive gene information to help treat cardiomyopathy. He continues to treat my symptoms. Does this sound normal, or should I look for another doctor?
Mm-hmm. For
Car,
some
you,
genes, that's normal. For some genes, we don't make big changes for your treatment. It's more info for family. So
yeah,
it's definitely a case by case. I would defer and ask them for more details. But sometimes from my side, that's what happens. I say, yeah, you'll follow up like normal, but this is really helpful for family.
yeah. And if you feel comfortable that your doctor, the institution, that the Heart Failure Center that he works at is understands genetic cardiomyopathy, I think that again, that's really important. From Pam, can testing show which copy of the gene is affected, is maternal or paternal?
No, it cannot. Great question. We would have to test mom or dad or people on their sides of the family to know.
Great, great. Jada says, for those of you who are GCs or know GCs, genetic counselors, how
Mhm.
have you advocated for insurance coverage for your patients' genetic testing?
It's a really good question. So the DCM Foundation does a lot of this already, discussing it, advocating, working with it. As a clinician myself, the biggest things that we do is make sure we include detailed notes with the test order the appropriate test, and advocate for our patients on what the process is. So, like me personally, I always make sure the patients know, like, don't send a sample in until you get a price estimate and you're comfortable with it. And they tell you, like, it's a guaranteed estimate if you don't lose insurance or things like that. Because I don't want there to ever be any surprises on a bill that a patient's going to get. And I only order places where I know I can guarantee that. Um, Broader coverage discussions are definitely complex and needing to be happening because each insurance is very different. A lot of insurances now do cover testing for a diagnosis of cardiomyopathy, but I often find the problems with getting it through are due to like coding and billing and notes and things where we can appeal, we can do peer-to-peer, we can request like written appeals. So there are different steps you can take. Um, it's certainly important that we be doing this for sure. The history of some of why testing's not always covered is kind of complex and relates to just genetic labs in general across all diseases. There's a bit of like history and growth and situation that has resulted in different things and a lot more than we can talk about now. But my go-to is you should not, ever get a surprise bill. I want to make sure I'm using a situation in a lab where you know the cost ahead of time.
Great. One from Elizabeth. She says life insurance. Did I hear this correctly? Genetic testing cannot be used to deny life insurance. You did not hear that correctly. Life insurance, they can either rate you with very high rates or deny you with life insurance. Life, um, long-term disability, or disability, and then long-term care are the three that you can be discriminated against. David asked, how would you rate Medicare insurance coverage for genetic cardiomyopathy? I guess one, would they pay for testing, and two, for genetic cardiomyopathy treatment?
Yeah, testing, it depends on the lab. Um, a lot of the labs, Medicare patients would not get a bill for the genetic testing. It depends on where you send it, but that's something that your doctor or genetic counselor should be able to tell you ahead of time, because there are places you can send it where you wouldn't get a bill.
Great.
Treatment, I defer to Greg.
Yeah, yeah. No, you know, I don't know. I would assume I have not heard anyone that says Medicare does not cover for heart failure. I mean, many people that have heart failure are older, maybe not because of genetics, just because they're older and their heart's giving out. But I would find, it's probably case by case basis, but I have not heard that it is bad. And I've not heard that it's wonderful either. So,
Yeah, I've heard like some medications can be more expensive or not covered, and I think becomes that delicate dance of what medicines are affordable and covered and available, which you can have with private insurers as well and commercial insurance. It can be kind of a tricky case by case.
yeah, we're going to do two more questions. I apologize. We have 57 questions. We can't get to them. We will try to answer them after the fact in an email. But let's do two more, then we'll have Nikki close out. I apologize. But thank you so much for the wonderful. We knew we'd get a lot of questions today. From Christy, if applying for life insurance, you have to declare genetic testing results if not diagnosed with cardiomyopathy. So you've got a positive result, but you don't have cardiomyopathy yet. Do you have to declare it? I would say, yeah. I mean, if they ask the question, and I think they pretty much all ask the question, have you been tested positive for any genetic conditions? So, I would think that if they ask the question, you have to declare it. So, and they'll uncover it, I would assume, the underwriters are going to go back and they have access to your medical records, and I would assume they would find it anyway. Cara, anything on that?
Yeah, you have to be honest. Like if they ask, have you had testing, you need to tell them. If they ask about your family history, right, you have to tell them. So that, like Greg talked about earlier, if you have a family history of all these people with heart failures or early deaths, like they take that into account too. Or if you already have a heart failure, that they take that into account. Um, so you have to disclose whatever they are asking. So if they're just asking about genetic testing, not related to symptoms, you would have to tell them.
Great. Anonymous attendee says, thank you all. Last question. I apologize. I'm DSP positive. I have three children under the age of 9. We want to get them genetically tested. Is it possible to secure insurance options that could cover them for the long term? If you have a good insurance agent, or family friends that do this I would ask them. I know people that have secured life insurance for their children at very early ages, but make sure that you meet with a qualified, especially independent insurance agency, independent agents that works for, because you may have to, look at 4 or 5 different companies that might provide it. But I have heard of this happening, yes, before. So check with insurance agents in your area. That is it. I apologize. We're going to miss a lot. But we need to close out, and I need to eat. I think everybody else does. So thank you for attending, Nikki.
All right. I have just a few final notes to wrap up. The Genetic Cardiomyopathy Awareness Consortium is helping connect patients with several genetic testing companies that offer testing to cardiomyopathy patients and their family members. So you can scan this code or visit our website, and this link will also be included in the follow-up email that goes out. And next slide. So as I stated, you will receive an email with a recording of tonight's webinar. So we'll include the links to the patient resources that Shauna shared, the insurance and financial information that Greg shared as well, and the genetic testing options. And also please register for our next webinar, which will be held February 18th, where we'll discuss understanding your genetic variant, what it means, and how to take action. Registration is open, and information can be found on the DCM Foundation and GCAC websites. And remember that even if you can't attend live, go ahead and register and you'll receive a copy of that recording via email. I'm also going to include a link to register for the next webinar in our follow-up email. And next slide. We definitely want to thank all of our sponsors whose logos you see on the screen. Their support allows us to present this important information. And thank you again to all of the patient partner groups for their ongoing support. And one more slide. Thank you all for joining us. We do hope tonight's discussion helped bring clarity, reassurance, and a sense of direction as you navigate next steps for yourself and your family, or for the medical professionals that joined us, perhaps for your patients. So be well, and we'll see you soon.
Thank you.